Next we have Dr. Miguel Morcillo, who is going to be talking to us about myopia and presbyopia, current surgical options.
Thank you very much for the nice invitation. I'm going to talk about the current options that we can offer to our patients that come to the refractive office looking for solutions of their myopia and presbyopia problem. These are my financial disclosures. As a refractive surgeon, I think these are probably the most the most difficult places to please because as we know that myopia is good for presbyopia, and many of your patients, I'm sure, they remove the glasses, they use the myopia for reading and near activities. So we can consider that people that ranges myopia from 1 to 150, they start to use readers late in the presbyopia, maybe a 50, 55-year-old. People that ranges 2 to 4 diopters will always enjoy an excellent near vision. And people that it's higher numbers of myopia, well, in spite they enjoy very close near vision, but it's true that this is not as functional as the previous situations. So these situations, I think, should be explained very clearly to these patients that all of them are going to lose this fantastic near vision they enjoy, but they will change into a new refractive range of vision. And we have to give the realistic expectations. Myopia and refractive lenses change is something very, very controversial and very careful to perform. It's not the choice procedure because we know all the higher incidence of risk of developing a retinal detachment is clearly described in the literature. Although I found this retinal detachment risk calculator online that points out like the main factors of retinal detachment risk, not having still developed the posterior vitreal detachment, and the presence of lattice degeneration in the periphery. Another problem that face here, of course, the potential surgical damage, the difficult AIOC calculation, especially if those patients did LASIK before, the complete loss of the accommodation, and especially difficult in early presbyopic, and they are less likely to end with 20/20 vision with uncorrected visual acuity. And of course, the irreversibility. If the patients are not happy, we cannot give back. Of course, this is a totally acceptable procedure if the patient is developing cataract. The classical monovision, I think this is still a good choice for many of these patients, although, of course, loses efficiency with time. We rely on the standing still accommodation that we know is going to be lost in time. The results of the monovision are different based on the different age of the patients, the best corrected visual acuity, the degree of binocularity. It's very important to find the dominant and non-dominant eye. And in my case, I am very frequently using a contact lens trial before, especially in those cases that are a little bit doubtful. The performance of the monovision in the myopia, it's quite good in most of the patients, although when you perform with laser procedures, is frequent slightly highest enhancement rate, because especially for the I4-FAR, the I4-FAR should be very close to the metropia. They are very demanding in this case. There is some percentage of reversion of this procedure. Some people at the end, they don't like it, and we have to go for the full correction. And it's possible they may use some spectacles for driving. And then in some conditions of long time near activities or low light conditions, they may use also readers. I think this procedure is better for easygoing patients. Less suitable candidates is people that is, in generally speaking, very demanding with the precision of the activities. That is why, in my suggestion, is most of the cases, if you don't find the patient very confident, do the contact lens trial. Another alternative, which I am not expert on this, is the presbyopic procedure provided by Zeiss. Suppose that it's enhancing it's like a monovision with enhanced range of vision due to this non-linear ablation that provides an extended depth of focus. Although the results I've seen in the papers are variable, and I found a paper which the results were not very good, or at least not so excellent as they provide. Another procedure we can offer is the presbyopic IPCL, which is a lens that I am using for the last 2 years when it got approved in UAE. It's a phakic refractive IOL inserted to a 2.8 millimeter incision and has currently the widest range of the market for corrections. The folding of the lens is very easy with an injector. The only thing we have to be careful not to trap the lens and put in a upside down position. And during the injection, we have to make like a 2 times injection, injecting the first half of the lens, waiting the lens to spread, sometimes get stuck, but it's very easy to implant like any other phakic IOL. Regarding the addition that we can choose for our patients, there are some tables that come, they consider the age of the patient we are implanting. Of course, they are advising the younger the patient, the less addition. Although in my small experience, I think that we have to go for the highest possible and tolerable, especially for the dominant eye addition. Because maybe the lens is working for early ages, but with time the remaining accommodation will be lost, and then they have to rely only on the addition that we have chosen. So maybe the highest the addition, the better. The presbyopic IPCL is indicated in people with thin or suspicious cornea, with high myopia, even with a mild amblyopia can still be used. People that is demanding for very good near vision, we can add high magnification. And people that are not happy also with the contact lens trial we did for monovision, they demand more vision. And in this case, we avoid the retinal risk because we are not removing the lens. According to the published results, these lenses provide very fast recovery. There is no need for IOL calculations that we can maybe face when we do a refractive lens exchange in pre or lazy patients. The volt is quite stable with time. More than 1 week, the volt remains the same. It's exceptional if you choose a very good addition, the use of reading glasses. And the reported allos or glare, in my experience, they are not very high. And of course, if they have, you have the possibility of reversing the procedure. And with a very good technique, the endothelial loss is minimal. So to finalize, I would suggest this decision tree to deal with these patients. I think especially for people that has not developed very high presbyopia in early ages, to go and try the monovision, to offer the monovision, do a contact lens trial. If the patient is happy and the laser procedure is suitable, then go for a laser procedure with monovision. If it's not possible, or because of the cornea has some problems, or the patient don't like the result, then we can offer the IPCL. If the IPCL is not the presbyopic IPCL, if the IPCL is not suitable, then we can see the retinal risk of the patient and consider with the patient the possibility of a refractive lens exchange. But if not, all these things are not possible, of course, then we always have to rely on try the contact lens and the monovision and leave the patient as it is. Thank you very much.
Thank you for that comprehensive overview. That was a nice overview. I have also got some experience with this presbyopic IPCLs. The challenge is what power to put in, because it's a progressive condition. Patients are there right from 40 to 60. Usually I put a plus 2.5 and a plus 3, plus 2.5 in the dominant eye and plus 3 in the non-dominant eye. And that seems to serve the patient even in their later years. Would you agree with that?
Yes, absolutely. I will not go for lower powers because, number one, you are dealing with patients that they have an excellent near vision. And then, of course, you have to tell your near vision will not be as good as you enjoy now, but it could be acceptable. But if you let's say, put a little bit more, you will be always on the safe side. So this is a good start. A good start.
Good. And I think the EDOF ICLs are also coming up now.
They are saying that the fact is that they told me about them 2 years ago, still delaying. I am curious to see.
It's available now in India.
Very good.